With this, we come to the next session, and that is the general awardees session. And can we have the slides, please? General awardees session, and basically these presenters have been awarded last year during the Kochi session. May I now request the next, please? Next, please. So the AIOS P. Siva Reddy International Award 2023 is jointly awarded to Dr. Shrish Kumar and Dr. George V. Putharan. And I would request Dr. Shrish Kumar to give his talk on double head pterygium excision with modified vertically split conjunctival autograft 6-year long-term retrospective analysis.
Also request the audiovisual to please set the timer to 10 minutes for each talk.
Yes, sir.
We don't want the timer for the session, we want the timer for the talk. So 10 minutes.
Okay. Good afternoon. At the outset, I would like to sincerely thank the Chairman Scientific Committee, Honorary General Secretary of AIOS and members of Scientific Committee and AIOC for selecting me for this honor. It's a prestigious award for the work done on double head pterygium. So many surgeons, they still consider pterygium to be unworthy of their surgical skills and surgical techniques, and this trivialization of the pterygium surgery combined with poor surgical technique is responsible for poor or variable surgical outcome. So the topic for today is the management of double head pterygium. It's a difficult management problem as you have a larger defect to cover, and as such we do not have any set protocol or algorithm to follow. And however, following techniques have been found to be effective in the management of pterygium, double head pterygium. So we have a superior and inferior bulbar conjunctival autografting. You can take graft from the inferior bulbar conjunctiva and the superior bulbar conjunctiva and place it on the bare scleral bed. And it's little difficult to obtain a thin graft from the inferior bulbar conjunctiva because of the adhesion to the tenon's capsule. It's tightly adhered to the tenon's capsule there in the inferior bulbar conjunctiva as compared to the superior bulbar conjunctiva. And this gives good results. And there are occasions where the superior bulbar conjunctiva is not available due to glaucoma filtering bleb, or in a case where you have the patient is a glaucoma suspect, or in case of double head pterygium where you need a larger graft to resurface the bare area on either side of the limbus. So in such cases you can even take a graft from the pterygium tissue itself. The conjunctival sheet from the pterygia can be obtained and it can be placed on the bare scleral bed. Here I am combining conjunctival tissue graft and conjunctival autografting. I am taking a sheet, conjunctival sheet from the pterygium on the temporal side and placing it on the nasal bare scleral defect. And after removing the pterygium from the temporal side, I take a graft from the superior bulbar conjunctiva and place it on the temporal defect. So it can be combined, and we have sent these specimens for histopathological analysis, and it's been seen that a section of the normal conjunctiva had 2 to 4 cell layered epithelium with no dysplasia or malignancy, whereas the conjunctiva overlying the pterygium was found to be uniformly thick with 8 to 12 layers of the epithelial cells and few goblet cells and few capillary networks, but with a similar absence of granuloma or dysplasia, and thus making it a good source of grafting in these cases. And so we published this concomitant use of conjunctival tissue grafts from pterygium itself without rotation in pterygium surgery. So this is done in patients wherein the conventional conjunctival autografting was not possible, And we found this particular technique has been effective in terms of recurrence rate or other surgical complications. It is no inferior to the regular conjunctival autografting. And we compared it with the inferior conjunctival autografting in indicated cases, those with superior filtering bleb or those who needed superior bulbar conjunctiva for future glaucoma surgery. And both the techniques of inferior conjunctival autografting and conjunctival tissue grafting from the pterygium itself are excellent alternative options with comparable outcomes and no additional risk of significant complications were seen in both the techniques. Coming to horizontal split conjunctival autografting, here it's a simple technique where you take a large graft and split it into two parts horizontally and place it on the bare scleral bed. So this is a small video showing the same procedure. The limbal end of the graft is placed on the more fleshy nasal defect and the part of the graft which is away from the limbus is placed on the temporal side over the smaller graft, a smaller epithelial defect. And we compared this horizontal versus vertical split conjunctival autografting in the management of double head pterygium, which was a retrospective analysis, and found both the techniques provide good results with comparable efficiency in terms of the rate of recurrence and other complication profiles. Coming to vertically split conjunctival autografting, you split the conjunctival autograft into two parts vertically and place it on the base scleral area. With the limbus to limbus orientation, if you place, you might end up having a gap. There is a bare scleral defect here. It may not be sufficient to cover the entire base scleral area. If you see here, the graft is small here and you have a bare scleral defect here, and this patient ended up with conjunctivalization of cornea. There is a recurrence happening from the lower end of the bare area. And in order to prevent this, you can split the conjunctival graft and slide it down vertically without keeping limbus to limbus orientation. This works well, and I have been doing it for the last 8 to 9 years. And if you see here is the fleshy pterygium, there is hardly any inferior bulbar conjunctiva available. You have enough conjunctiva in the superior bulbar area, and you split it into two parts without changing the orientation of the graft. You just slide it down and place it on the bare scleral defect. Without changing the orientation of the graft, either you suture it or glue it. So we did a retrospective comparative study of vertically split conjunctival autografting for double head primary pterygia, and we included 94 eyes, and the follow-up period was 6 to 70 months with an average of 17 and a half months. And these are the complications we encountered. None of them are very serious complications, and the recurrence rate was just 3.18%. Only 3 out of 94 cases had recurrence. One had a temporal recurrence, one nasal recurrence, and in one case both nasal and temporal recurrence was seen. And when we analyzed, it was actually in 2 of the cases we had graft loss, and in one case we had severe retraction of the graft. We compared it with the other studies. Of course, it's not vertically split conjunctival autografting, but the study for double head pterygium by different authors, and the numbers were much less as compared to our numbers. But the recurrence rate was comparable in these studies. Some of them have done horizontally split conjunctival autograft, and some have adopted amniotic membrane transplantation. This is our post-op picture of the video which I have shown. And so double head pterygium excision with modified vertically split conjunctival autograft. We followed them up for 6 years, and the results were encouraging, and the procedure is very safe in these double head pterygium cases where the superior bulbar conjunctiva may not be sufficient. And so we even published one more article in Women Journal of Ophthalmology, similar procedure, but we have used glue here, and the outcome was good. The recurrence rate was less than 4%, and we even compared vertically split conjunctival autograft with and without limbal orientation. That was again published in IJO, and both the techniques resulted in good outcome. So to conclude, modified vertically split conjunctival autograft is a safe and successful technique in double head pterygium. Can be adapted in most of our cases. Thank you very much.
Thank you, Sirish. Thank you for that wonderful lecture, and also thank you for your contributions in pterygium surgery. I know that
Thank
you
you a
have
lot, madam.
contributed a
Actually,
lot. Thank
I
you.
used to present a lot of topics in pterygium, and Dr. Namrata used to be my co-instructor way back in 2003, 2004. I had good number of cases as, for presentation, but no publications. She only told there is no publications at all. Nobody recognizes your work. So since then I started working, and now I have 19 cases.
Yeah, so everybody recognizes with P. Seva Reddy International Award, which you are going to get today. Thank you so much. It is my pleasure to introduce the next speaker, who has traveled from Bangladesh, and I would request Dr. Amit Purwal to call him.
So it's my proud privilege to welcome our international guest, Dr. Shah Monir Hossain. Sir, please welcome on the podium. I request you to give your keynote address. Keynote address on public health initiatives in promoting eye health, integration of eye health into primary health care. He is our international guest who's come from Bangladesh all the way here to deliver his keynote address. So over to you, sir. He is also the president of Public Health Association, and he's doing a tremendous work in public health awareness.
So first of all, I must thank the organizers to invite me in this AIOS conference. I'm not an ophthalmologist, I'm a public health expert, but I work in ophthalmology quite long. So I'll be talking on the public health initiatives in promoting eye health and the integrating eye health into primary health care. My talk will be limited with this Bangladesh concern, not as a global concern. There is no lovelier way to thank God for your sight than by giving a helping hand to those in dark. Helen Keller's quote. So this is the philosophy of the public health in ophthalmology. So actually, we should work together to help people, to those in the dark. So my talk will be mostly on these socio-demographic situations of Bangladesh and what is the access of the eye care by the marginalized people, the vulnerable group of people, their challenges, and there are some opportunities also. And the community engagement, one of the most important issue in public health, the involving community in this overall preventing blindness issue and the community ophthalmology. The role of community clinic, Bangladesh in the primary health sectors, most of the primary health services are provided through a one-stop delivery services. We call it community clinic. Actually, this community clinic concept started a couple of 2 decades back, before most of the primary health care was provided through a domiciliary service. The health workers used to go home to home and provide some primary health care services. But the government has decided to establish community clinic for every 6,000 populations. And this community clinic is now playing a very vital role and backbone of the primary healthcare services in Bangladesh. So I'll be discussing a little on the role of community clinic, and I'll try to give a linkage between the community clinic and community vision centers. That is another approaches by the government of Bangladesh to establish community vision centers to bring the people and to particularly related to the eye care and particularly the decreasing the backlog of the cataract of the country. And finally, a few recommendations. So this is Bangladesh with a population of around 170 million people, and the life expectancy is now increased to 72. Just 50 years back, it was 49 years on the life expectancy. So that has bring down up to 72 years, but still we have 30 million people are living below the poverty line. So that's a big challenge for the Bangladesh populations. So the prevalence of visual impairments by these socio-demographic characteristics, I was involved in the National Blindness Survey, was done in 2020, and we did it to see what are the causes of blindness and what are the interventions that needed the blindness. And the highest prevalence are in this illiterate group, mostly, and that is again the vulnerable group, lowest income group, and not working group, those who are not working, particularly at the rural area as well as in the urban slums. And there is disparities in urban and slums disparities, urban and rural disparities. So that was the findings, outcome of the prevalence of the visual impairment. I'm not going details of it statically, but just the crude of that findings. So our concern is this 30 million vulnerable people are living in Bangladesh with the diverse socioeconomic challenges, diverse cultural identities. Geographical distribution is different because there are different types of geographical distributions. People living in the hard-to-reach area, people living in the ethnic groups, those are these vulnerable groups. And their employment opportunities are limited, and livelihood are fragile, and social identity and status is very low. So we are concerned about this group of people, and particularly women in such group. Additional challenges is there, and there are very few resources available to access education, health, and economic opportunities. So with this concern again that reaching this population as providing accessible and affordable healthcare, especially eye healthcare, is always challenging. So we have to find out the way how to reach this group of people to ensure the universal eye health coverage. So that is very important challenges in Bangladesh. But we have the opportunities again. The Bangladesh has remarkable progress in the socio-economic development in the recent decades and successfully achieving targeted health indicators. Not only the eye health indicators, in general the MMR and IMR, all the health indicators has been achieved successfully. Because of the health system restructuring and strengthening the health system, addressing the needs and the priorities of these vulnerable populations, particularly within the primary healthcare settings. So with this, these are the opportunities that Bangladesh is coming up for mitigating the challenges of the vulnerable group to provide primary health care. So one of the most important work that needs to do, and I think every region had different aspects, Bangladesh, India, or even globally also, every society have its own specialty. But we need to bring the community in the services. If you really engage the community, you can really work on that. So if this engagement of the community and linking with the community vision centers with the community clinic for primary eye care is very important. So we have a pro-people healthcare initiatives in Bangladesh. We call it community clinic. Why I'm talking it's pro-people? Because this community clinic is owned by the people, not by the government. The local people donate the land for the community, these clinics. Government will only provide the human resources and also the logistics to provide services. But there are community group, this composed of the community people who are really managing the community clinic. So this is an unique private partnerships technique. So we call it PPP. It's a good example of private partnerships, the public-private partnerships resources. And this is important that constructions done by the government, but management done by the community people. And there is a political commitment which is very much needed for any good opportunities in the healthcare. If we don't have any political commitment, we really cannot do it. So the political community clinic is the initiatives of our present Prime Minister. So he used to give a voice mail through this mobile phone and reaches around 40 million people so that the people can use this community clinic. So this voice mail is a very good initiatives as a political commitment. And the UN nations has already recognizes these initiatives as the Sheikh Hasina initiatives. So this is the present government a strong political commitment to provide health services and also the primary care health services, and also integrating primary eye care into the primary healthcare systems through these community clinics. So community engagements, the community people are sitting together and they are providing these services. So there are community groups, and every community groups there are community support group. The community support group is providing support to the community groups and the community clinics. Also there are union parishad, they are the elected people, and they wish to provide support to this community group. And the landowner of that community clinic is the member secretary of that group. So there are these community leaders, women community leaders, the religious leaders, the school teachers, they are the members of the community groups. So 13 to 17 members are in these groups. And there are 5 female members in this community group. So the community group is an integrated part of the health system in Bangladesh. So as I said, this is a one-step delivery service and is a good example for public-private partnerships. And community engagement is one of the most important issue in these community clinic services. And women empowerment gives an opportunity, and people's satisfaction, that's very important. People's satisfactions and created a social movement. So going through this, actually the linkages between the community clinic and the community vision centers. Community vision centers is there. So I'm just finishing within 1 minute. So the Ministry of Health has developed a national eye care program that is one of the most important program for the primary health eye care as well as overall eye care in Bangladesh. So these community groups, community clinics are responsible for screening the eye patients, referring to the vision centers, motivating people. The awareness raising is another important issue, changing health-seeking behavior, follow-up, and eye health surveillance. So they provided these district health information systems through this follow-up by surveillance. We did an assessment, the assessment of the primary eye care using the eye care service assessment tool. So that is mostly depend on the World Organization's 6 health system block systems through the governance, financing, service delivery, human resources and for eye health, infrastructures, medicine and technology, and health information systems. And that assessments gives us the opportunity to see the present situations of the primary eye care of the country and find out the gap between the desirable situations. So the gap that was identified through this assessment, and we could support the government to develop the new guideline for these primary eye care services and to particularly promoting the eye health services through the community peoples. Another study was done to see the barrier to the uptake of the eye health services of the children in the rural Bangladesh, a community-based cross-sectional survey that also give us this information, really what are the challenges. Around 50% the caregiver does not have the knowledge where to go for the services. So there are a barrier, lot of barrier in uptaking the healthcare services, particularly for the children eye. So I'm skipping this one. And so another study was done in the urban area, particularly in the slums area of Dhaka city, and we found that refractive error is one of the most cause of eye diseases, and there are other eye diseases also. So the prevalence of the refractive error, allergic conjunctivitis, visual impairment, and cataract among this group of people suggests the importance of the increasing access to the eye care services. So with this, I'd like to conclude that though Bangladesh has a national vision eye care action plan, which is in line with the global strategy for the universal health coverage, but we need more data to, and comprehensive assessment should be done and for this productivity of the eye personnels and the scope and quality of the service available throughout the country. So we have some recommendations. So eye care service should be prioritized, and it should be within the broader health agenda. Actually, it should not be separate health agenda. It should be within the broader health agenda, so that understanding the economic challenges for the ophthalmic morbidity and vision loss, and there should be more investment in the eye care services, so that eye care services can be integrated into the poverty reduction strategies, policies, and initiatives. With this, thank you very much. Thank you all.
Thank you, sir, for your initiatives on promoting eye health. It was an honor to have you over here. So now I call upon the next joint awardee of AIOS PC Reddy International Award. And this is none other than my very close friend, Dr. George V. Putran. He is the man behind the RD wall, and he's going to talk on evolution and widespread use of an affordable aqueous drainage implant. So over to you, George.
Thank you, Amit, and thank you, AIOS Scientific Committee, for this huge honor. I am humbled, but also I'm feeling very proud to deliver this lecture. I have no financial interest in the subject matter of this talk. So affordability, prohibitive cost was the main deterrent for uptake of tube surgeries in the developing world. And there were two professors, Professor Paul Palmberg from the Bascom Palmer Eye Institute in Miami and Professor Alan Robin from the Wilma Eye Institute in Baltimore. Both of them were very passionate about providing an non-valved bowel glaucoma drainage device to the developing world, for the portions of the world that could not afford to pay 60,000 Indian rupees per device. Unfortunately, they were not able to convince various companies that owned the bowel glaucoma implant at that time to do so. Professor Alan Robin has been a one-man army guiding the Aravind glaucoma services right from its inception, and I'm extremely proud and privileged to have a much older version of Professor Robin here in the audience today. And I know for sure that Professor Palmberg and Professor Robin had absolutely no difficulty in convincing Professor George Barwell to allow Orolab to use this design which he had bequeathed to the glaucoma community. So Orolab aqueous drainage implant is an affordable version of the 350 square millimeter Barwell glaucoma implant. So reverse engineering the design was not difficult for Orolab. But to cut a very long story short, Orolab had to innovate with cost-effective manufacturing. Liquid silicone rubber molding, which was used for the Barwell glaucoma implant, would have involved lot of investments in terms of machineries and overhead costs. Orolab innovated to use a simple compression molding process, but the difficult part was to identify compression moldable medical grade silicone. The process, which started in 2005, culminated in its launch in 2011 in the Tamil month of Adi. And this, in the Tamil calendar, the month of Adi is supposed to be auspicious, and it's also coincidentally the month where good products are available at highly subsidized rates. We were fortunate to have Professor Palmberg with us for the launch. He also made a couple of other visits after that to train surgeons at various Aravind Eye hospitals. Now it was our turn to train and teach. The concept of the non-valve device was a little new, and it was an absolute joy to spend hours late after hospital hours for almost 6 months to develop an animation to simplify the principle and surgical technique of this non-valve device. I used to pounce on every opportunity I got in the early part of the last decade to try and make surgeons comfortable using this non-valve device. Later on, I was fortunate enough to volunteer my time for Orbis International, and I thought the hospital-based training programs of Orbis International was an excellent platform for me to reach out to so many young surgeons in reputed institutes across India. Multiple awards followed with our work on the RD. At the World Glaucoma Congress in 2013, a couple of times at the American Glaucoma Society annual meeting, and also at the annual conference of the Glaucoma Society of India. The work with this affordable device again made to the cover of multiple issues of Journal of Glaucoma, and also the results, our initial results of the RD in adult refractory glaucoma was our first publication about the Orolab aqueous drainage implant, appeared in Ophthalmology Glaucoma. Very soon we had this publication in pediatric refractory glaucoma, our experience of the RD in pediatric refractory glaucoma in BJO, and thankfully both these publications the results were more than comparable to the initial results in literature with the Molteno, Bowell or the Ahmed glaucoma valve. So by the late 2015, we started burying tubes in the patient's own sclera. This is a 23 gauge needle generated 4 millimeter long scleral tract for tube insertion, and we soon realized the conjunctival healing over the tube insertion sites had to be seen to be believed. I consider this work, which was published in the American Journal of Ophthalmology, as most important in my career. Some of the modifications we did, where to place the tube so that there is minimal contact with the upper eyelid, how to make available an optimal length of 2 millimeter, which is neither too long, too short. All this and much more has been beautifully described in this paper. Most importantly, the dreaded complication of tube exposures and tube extrusions in the pediatric age group to a large extent was taken out of the picture. We also looked at, there were some practice pattern changes also along the way. We looked at our preferred second quadrant of choice of conjunctiva for tube insertion. We used to do a lot of infranasal tubes, but we soon realized even though infranasal tubes were doing as well as the supratemporal tubes in the adult refractory glaucoma, the safety and efficacy were being compromised, and now supranasal quadrant is our go-to quadrant for if you need to, for any reason, need to repeat the GDD. We have also published on RD as primary surgical intervention in multiple secondary glaucomas, in iridocorneal endothelial syndrome in Graffe, again neovascular glaucoma in BJO, and also outcomes of RD in aniridia associated with glaucoma in AJO. It was an absolute joy once again to work closely with our vitreoretinal colleagues in select situations of refractory glaucoma, where we published our results on pars plana tube insertion. We looked at various complications of this non-valve device, outcomes, incidence and outcomes of retinal detachment surgery. Hypertensive phase, we had evidence. There's not much of literature on hypertensive phase in non-valved implants, and we could answer so many questions from fellow glaucoma surgeons with evidence after this publication came up. We looked at incidence and outcomes of suprachoroidal hemorrhage following RD, and again, early and late hypotony following non-valve device was another major deterrent to the uptake of tube surgeries. This was again another opportunity to work closely with Orolab. We could come out with the 3-0 multifilament nylon. Every non-valve device now gets the supralaunch suture intraoperatively. It's made surgery so much more safer. We have the RD250 available, and I can vouch for the fact that these are all products that have been brought out by Orolab with very little business interest in mind. They are absolutely a social commitment to the community. Again, another publication which gave us a lot of satisfaction, we found that eyes with pre-existing RD, subsequent to phacoemulsification, still had good control of intraocular pressure, and thankfully long-term surgical outcomes are also very encouraging. It all started with affordability, but I tell you it's now more of, it's also about efficacy. We see larger surface area, thinner wall, low profile blebs, whereas bleb encapsulation and T-nonces continue to be a problem with valve implants. I would like to mention just 5 individuals here. My mother, who is an ophthalmologist, father was an ophthalmologist, Padma Shri Dr. G. Nachiyar, who is my mentor in ophthalmology, my grandfather, who was also an ophthalmologist, who is a contemporary of Dr. P. Shivareddy, and my mentor in glaucoma, Dr. Krishna Das. I'm grateful for my mentors and colleagues at Aravind Madurai, and more than Professor Robin was already a family. Professor Palmberg also became family, and more than a decade and a half, I used to wonder why these much acclaimed super specialists would want to make multiple visits to our part of the world. It took me a good part of 10 years to realize these American Academy of Ophthalmology's outstanding humanitarians were working tirelessly to improve eye care worldwide. And it was truly my privilege to play a vital part in the evolution and widespread use of this non-valve implant. I am so proud that some of the initial lives that were touched were in some of the most remote parts of Tamil Nadu. I truly believe this implant is preserving useful vision in so many patients and will continue to do so. I will leave you with just one email that I received from Professor Paul Palmberg. This was after the American Glaucoma Society meeting last year, where he talks about how blessed he was with the gift of, and he was thanking his trainees for allowing him the gift of being part of their career, and he ends by saying, as I said there, my wish and prayer is that at the end of our careers and lives, that we will hear a voice saying, well done, good and faithful servant. Thank you so much.
Thank you, George. It was really emotional, and seeing all the photographs and mentors there in the last few slides, it is an emotional moment. So now I invite our next awardee, AIOS Shroff Award, Dr. P. Mahesh Shanmugam, for his contribution, both qualitative and quantitative in nature, in the posterior segment of the eye. Over to you, sir.
Good afternoon, and I thank the AIOS for this great privilege and honor on bestowing the C.N. Shroff Award instituted in the name of the pioneer. So this talk will be about vignettes or small snapshots over a career spanning the last 32 years. So it was Dr. Badrinath who introduced me, inducted me to the field of vitreoretinal surgery and trained me, and it's my obeisance to him, and also my gurus, Dr. Gopal and Dr. Tarun. And my obeisance to people who continue to support me, Dr. Ramani and Dr. Janaki Raman of Shankaraya Hospital, who continue to support me, and without whose support, I will not be where I am. Though the award is given in my name, it's actually the team. Though the idea may have originated in somebody's head, but it's actually the team. Without the team, nothing works, and it's thanks to my team as to what we have been able to achieve so far. Lastly, thanks to my family, without whose support I will not be where I am, and particularly to my wife, who has been standing by me over the last so many years. So one of our strengths is in cost-effective innovations, and let's start with the AIOS itself. So it was we who showed that we can use mundane devices which are lying around in the house, like the handycam, to image the fundus in the era of very expensive fundus equipment. So this we did innovate in 2006, and we got the Rangachari Award for this in 2009, where we put a torchlight on the handycam, and we were able to do an indirect ophthalmoscopy with this device. And these are the images which we could obtain with these devices. And subsequently, we went on to make the indirect ophthalmoscopy with the mobile phone. And these are some of the images with which you can achieve with the smartphone as an indirect ophthalmoscope. Then we went on to create a direct ophthalmoscopy with a smartphone. So this was about 100 rupees a LED bulb and a battery, and we were able to make the smartphone as a direct ophthalmoscope, and these are some of the images of the mobile phone as a direct ophthalmoscope. Recently, we did a study comparing this particular device where we had spent about 100 rupees to create this device versus the commercially available devices which cost upwards of around 20,000 or 15,000, and found that our device actually equaled or surpassed the other commercially available devices in diagnosing diabetic retinopathy. Next, we went on to pediatric fundus imaging, which is a burning issue. We need less expensive equipment to image the fundi of infants, particularly to decrease the burden of retinopathy upon maturity. And some time back, we found that you can use a nasal endoscope to image the fundus, and this we did publish. And you can see the images of the retina taken with the nasal endoscope, and this is the gonioscopy, which can be done with the nasal endoscope as well. Of course, it's difficult to, if you were to make an equipment out of the nasal endoscope, it costs about 150 to 200 times less expensive as compared to the commercially available devices right now. And naturally, I am unable to get any companies to be interested or industry partners to be interested in making these devices. I hope sometime in the future we'll be able to create one out of this. Moving on to another innovation. So we know that polarized glasses do improve the vision. So this gave us a thought as to see if polarized glasses can improve vision beyond the best corrected visual acuity of patients with multiple retinal and optic nerve devices. There's one such clinical example. This was a 32-year-old lady who had a peripapillary cavernous hemangioma and had a subretinal hemorrhage. We displaced the blood and with anti-VEGF as well as gas, and then subsequently did photodynamic therapy. So she cleared, but then she had only about 660 vision. So you can see that she's struggling to read. She tilts her head this way, that way, and whatever you do, she is unable to read. Then we put on a circular polarizer in front of her. You can see that her vision instantly improves from 636 to 66. So this gave us a thought process that a circular polarizer, this is not a regular linear polarizer, but it's a circular polarizer, showing that we can improve the vision of patients beyond best corrected visual acuity with a particular polarizer. So once you take it off, you can see again she goes back to bending her head this way, that way, and struggling to read what she was able to read with this, and she in fact demands for this particular lens. So we did do a study, and this included patients with retinal diseases, optic nerve lesions, and optic nerve pathway lesions of various pathologies, diabetes, RVO, AMD, PFT, and such, and found that in about 80% of the patients we were able to improve the vision one line beyond the best corrected visual acuity, and in about nearly 50% of the patients we were able to improve vision by about 2 lines, and 20% more than 3 lines of vision. And in fact, we did receive a patent on this particular innovation of using the polarizing lens in optic nerve as well as the retinal diseases recently. Moving on to photobiomodulation. Photobiomodulation is a treatment adjunct which can be used in patients with retinal diseases such as age-related macular degeneration, diabetic macular edema. We innovated this very simple device of a custom-designed yellow-green filter, and the patient will gaze at the sun through this filter for a particular period of time. This was how it was done for a particular period of time in a day. And this is a classic patient many of us come across in our retinal practice. We have done everything possible, but still the patient continues to have diabetic macular edema, and we are unable to help them. So here you can see that with this photobiomodulation, what happens? The macular edema went down considerably just by staring at the sun through this particular device. And did we harm the eye or did we harm the macula by asking the patient to stare into the sun? But the visual field shows that there has been no worsening of the central visual field. In contrast, the untreated eye continued to worsen or remain the same, whereas the treated eye, the macular edema decreased. And once we stop the treatment, you can see the edema coming back, indicating that it's the treatment which works in decreasing the edema. So a very small study we did. In about 11 patients, we found that 70% of the patients, the macular edema decreased when we added the photobiomodulation to the existing treatments or as a standalone treatment. So we are in the process of finding alternates, because vagaries of the sun, sometimes it can be cloudy, sometimes it can be very bright. So we are trying to find digital devices which can replace the sun and use photobiomodulation as an adjunct to existing treatment. Similarly, we have innovated in the surgical space. So here we have used an illuminator to localize the break during a skeletal buckling surgery because the novices find it very, very difficult to localize the break precisely, and the illuminator precisely is able to localize the break. And we have also created a illuminated cryoprobe, again a cost-effective invention, like you can make this yourself. Once again, this improves the precision of the treatment as well as the localization of the brittle breaks. In fact, we have a paper on the recent innovations in skeletal buckling, thereby making it popular once again. Coming on to academic space, we created this RetNet India, which was founded in September 2005. That was the first digital-based discussion forum, and subsequently, of course, we have many of these. But this is what we started with in 2005, which had members all across the country and other parts of the world as well. Pre and post Shankar Nethralaya, around 1/3 of the publications were during Shankar Nethralaya, and subsequent 120 publications or so subsequent to the time after Shankar Nethralaya. And we have trained about 75 fellows over the last 15 years in Shankaraya Hospital. And what do they see? They see that with vitrectomy surgery, there is always a hope. So we do stage 5 ROP surgery, a closed funnel, a closed vitrectomy, but then this is one of the rare situations where we had to do an open sky vitrectomy because the corneal opacity was there, and in addition to that, there was a stage 5 ROP underneath that. So we opened the cornea, removed all the scar tissue, and allowed the traction retinal detachment to reattach. So this is what our fellows see and learn, knowing that there is always hope with the vitrectomy surgery. So that's the open sky vitrectomy and then closing the thing. And this is an end-stage diabetic eye disease. This is a one-eyed patient with extreme diabetic traction retinal detachment or a combined retinal detachment with absolutely no visible retina. And with very meticulous surgery, we know that we will be able to reattach this retina as well. So it's a bimanual dissection of all the fibrous tissue. You can see that there is something resembling the retina underneath all this fibrous tissue. So there's absolutely no cleavage plane between the fibrous tissue and the retina. And post-dissection, we left this eye with perfluorocarbon, and this is what we began with, and this is what we ended with at the end of the surgery. And there is another quadruple amputee. This is the only eye remaining, and this was after removing the synechia. We did an open sky and dissected all the scar tissue from the anterior chamber. And what you find is, during the process, you find the whole retina prolapsing outside. You put it back, and with viscoelastic, and the curve process, we went back inside to find a closed funnel retinal detachment, which we opened up to reattach, and this gentleman still retains about 3/60 or 4/60 vision, and this is the only eye. And as I mentioned, he's a quadruple amputee. He's a war veteran. You can see that the retina has gone back despite a fold around the optic nerve. We do dabble with the tumor-related retinal detachment. This is a retinoblastoma in a one-eyed child with a recommended retinal detachment, where we're left with no other option but then to resect the tumor and then reattach the retina. So the journey continues, and thank you once again for this great honor and patient listening. Thank you so much.
Thank you, sir, for this wonderful talk. And with this, we now come to the conclusion of the AI General Awardees session. And I welcome all of you all to the inauguration, which is going to be in Hall 1. So congratulations to all the awardees once again. It was a pleasure to listen to you all. All the awardees are here. Can we take a group photograph with the awardees?
Dr. Guru Prasad, sir, can you join us on stage?